is that's great love. That's great love for us, Dr. Joyce, to come and share for us on this topic on empowering the caregiver to be able to help where the family members or relatives who may be having terminal illnesses, and also to have persons maybe having some other special needs like autism, cerebral palsy, among the others. So we are privileged to have Dr. Joyce Wangari, and we are honored to have her be willing to give us this for free. We know it's a very, very important area, and as many of us requested, we need support on that area. So we are grateful for her. Dr. Joyce is a clinical psychologist. She's a consultant psychologist. She's a trainer. She's also a speaker. Even she also gives the TED Talks. So we are grateful and honored to have her. And I think because we'd like to have enough time for her to be able to dispense the knowledge she has for us, I will invite her to take over and so that we can be able to move on. And as she'll be taking over, I will just request once we join, we can make sure we mute our mic. Sausa, you can mute. Thank you. And
sorry, I think I muted you by mistake. James, are you done? Sorry, were you done speaking, James?
You're welcome. You can continue.
Okay. All right. Thank you so much. Thank you for having me. You have a wonderful initiative that you're doing, and I am so honored to be actually amongst friends. I see lots of colleagues I know, a lot of the people I have worked with in the fields of either psychology, research, disability. I can see a lot of my disability colleagues here. I also see a few people who I've met in different forums, and it's amazing that Zoom can allow us this opportunity also to just be online all at once. So I have been with James Njogona's initiative, JK Wellness, for a while now. It's amazing how with just enough accurate information, people can make decisions and also change attitudes. The work you're doing, James, is touching so many lives. So it's really a privilege for me to join in today. So today we'll be talking about a subject that is close to everybody's heart, because everybody either knows somebody who knows somebody or is somebody who is living with a disability or special need, and that's actually our focus today. So I'm seeing the expectations still coming in the chat, and I'll begin my presentation. Kindly, if you're coming in, just mute. I'm trying to also have people to mute themselves instead of me having to do it. Okay. So, and as we still have more people streaming in, I can still see more expectations in the chat. A lot of people saying, hoping to recharge by tapping the wellness positive energy from the forum. I expect to hear more about how terminal illness affects family members and the society. Thank you so much for all your expectations. Keep them coming. I'll be happy to just, sorry, I'm trying to mute people over here. So I'll be happy to take a lot more expectations as we continue. So as you've heard, my name is Dr. Wangari, and my website is wangari.africa. And I'll be happy to basically take us through a couple of things today on empowering caregivers of family members with people with disabilities and other special needs. As we know, this is our a Monday series where we get to learn together as well as ask questions. So feel free at any time to put up a comment or a question in the chat, and then at the end we'll have a discussion. So we'll look at some definitions, some types or examples. And when we talk about symptoms and progression, it will be a little bit more technical. We'll be talking about some awareness, some knowledge, so that people understand because we have different conditions. And what I'm mostly interested in, of course, is the caregiver's role in all this, the emotional and psychological impact, treatment and care options, communication and decision-making, support systems, ethical considerations, and of course, the conclusion. I must say some of the information may be triggering. I am hoping that this webinar is comforting for those of us who might be struggling with anything or who may have people in their lives they take care of who are also struggling. So I hope that in that sense, we'll all be able to learn and also be comforted. So what is terminal illness, special, we talk about special needs, disability. So a terminal illness is a medical condition or disease. Most of the time it has no known cure. We just see who is still unmuted. Please mute yourself so that we can share the bandwidth. Yeah, thank you so much, everyone. So many people coming in. Thank you so much. And the illness is expected to lead to death of the affected individual within a relatively short or long time. What I'm going to do, I'm going to make you host, JK, then you're going to help me. Is that okay? JK, you're now the host. Can you hear me? Hello. Okay, also let me know if at any time. Okay, so what you'll need to do, kindly, JK, go to the bottom where it's written share screen and click multiple participants can share so that you enable me to share screen again. Thank you. Sorry about that, everyone. I'm glad with the high interest. We have over 88 people already in the Zoom. So this is wonderful. So as we said earlier, keep your expectations coming. Neema says there's no sound. I think that's on your side, Neema. Check your audio settings and also create the, please create the, so JK, I'm waiting for you to enable me to share screen. And Neema, you may try to log out and come right back. Is that okay? Okay. So we're just trying to get some order in the Zoom room. Thank you, everybody, for muting. JK, are you able to enable me to share screen? You are muted. Let me send you a prompt to unmute. Yes, JK? Trying to see. Okay. Okay. Yeah, no, sorry, I'm on a Zoom that does not have a co-host option. Sorry about that.
Okay, you can hear me now?
Yes, I can hear you. I'm saying go to where there's a green arrow at the bottom. Just say multiple participants.
The green arrow?
Yes, so that I'm able to share screen. So what you do, you click beside it where it says multiple participants can share.
Meet.
Yeah. We're almost 100. We are doing very well. So keep your expectations coming, write in the chat. I'd like to know what you're here for. What would you like? Some of you, I know it is a direct experience. Some of you want to know a lot more from questions. Okay, JK, if you're unable to do that, you can return me as host. I was just waiting for you as I was chatting. Yeah, sorry about that, everyone. These are usual technical hitches. So I see
where there's a green line.
Yeah, where it's written share screen on the side, just say multiple participants can share. Okay. Yeah, we came pretty early. We wanted to set it up, but I thought I could do both, but I realized the crowd is growing. It's good. So I hear someone saying, expecting to hear more about how terminal illness affects family members. I still am unable to share. So just make me host again. Sorry,
Okay,
everyone, about that. Yeah.
let's
So yeah, Daki Duba says, it's Dr. Wangari. I'm glad to meet you once again. I can't wait to learn. Posa is suggesting about hosting. Monica Ohingo says, I want to know more about autism and taking care of the elderly. Thanks. Wow. Okay. Yeah. Anybody else? Any other expectations? We don't have time to listen to everyone talking, but you can just type in the chat. What do you want to learn today? JK, have you made me host? Do you know how to do that? Okay,
yeah,
so
yeah.
okay, make me host then if you know how to do that. You've made Mary Moriah host, not me.
Oh, maybe.
Okay, Mary,
Okay.
do you know how to make me host? Mary, do you know? You go to participants and then you
No,
select.
I don't.
You don't know. Okay, go to participants, then select Joyce Wangari. There's an box at the end. You say make host. Let me see if I can reclaim. Okay, I've reclaimed host. Yeah, so sorry everyone. So I'll do both the hosting and the slideshow. So let's continue. Thank you so much. Keep your expectations coming. So we are full. The Zoom room is full at 100, and I know more people want to come in. So really, really good turnout today. So I was just defining terminal illness and getting your expectations. Keep your expectations coming. So some causes are, of course, genetic. We have also environmental causes, and we talk about different diseases: cancer, heart disease, neurodegenerative disorders that affect the nerves, like ALS, and also genetic conditions. So the illness depends, you know, in a number of factors like progression and overall health of the person. So coping with diagnosis is one major thing that we have to really consider, because as caregivers, we are working with people, or we are living with people who may or may not understand what the condition is. It is one thing to know it in your head, but it's another to accept it in your heart. And both the person with the condition and also the caregiver needs to be able to cope with the diagnosis. So usually there's a major challenge. We know it can be overwhelming. We're going to look at some examples now of some conditions. In the field of disability, this word has become very popular. We talk of neurodivergence. You can see it's an umbrella word for all the different conditions that might be affecting psychological function. And I am a psychologist, so I work a lot with neurodivergent people. So ADHD, OCD, I don't have time to go into each and every condition here. This is not an exhaustive list. It's just a few examples. I know some of you wanted to know a little bit more about dyslexia. A few people asked about autism, and we'll go a little bit into some of them, not all of them. Okay. Some people also wanted to know the difference between Alzheimer's and dementia. This are another example of, conditions. So we know that Alzheimer's is a type of dementia. Okay. And what is dementia? Dementia is the slowing down of the brain, mostly associated with age. Okay. You may also have many other causes, such as diseases, when you get a stroke, some vitamin deficiencies, And we usually say that Alzheimer's is irreversible. We know that although we can improve symptoms or slow progression, but dementia is potentially reversible. It's actually possible to reverse it and manage it, especially the type caused by some drugs or alcohol or metabolic disorders. Those are actually possible to actually eliminate or completely remove. Some of other conditions, such as autism spectrum disorder or ASD, you can see some symptoms there. Maybe the person has problems with communication, and you can see some examples like not responding to normal social cues and a lot of learning challenges. And others are like dyslexia, and you can see from actual the example of how the letters are written, and in the brain of a lot of people with dyslexia, they will have a problem processing some letters, And this is exactly how it appears in the brain. So instead of keep calm, you can see how it's written. Some letters are opposite. Okay. How about ADHD, attention deficit hyperactivity disorder? We have comparison of that with autism here on this slide. In ADHD, you might find that people have a problem just with focus, concentration, what we call attentional control. So making spontaneous plans and struggling to get organized would be some of the symptoms. But if you contrast that with another separate condition called autism, in people with autism, a lot of them want to arrange a lot of things in order, and they have a strong need for order, and they get very upset if any plans get interrupted. So they are masters of routine. And those are just some examples of what we call disabilities, special needs. You can see the list is long. There's so many different ones. Visual impairment, that's a more visible one. There are some hidden ones that you cannot see with your own naked eye, you know, sickle cell disease. We have quite a number of people working on different programs. And in Kenya, for example, you find organizations that are either condition specific or they'll cut across different conditions and trying to help caregivers. And now we do have very, very distinct caregivers groups. I hope if any of you are working with caregivers, you can also share your contacts. This is a good forum for us to keep in touch even after this. And obviously this recording will be availed to us. So let me just mute whoever's there, Lucy. So a few more examples, just very quickly. As I said, I don't have time to go into all this, but a lot of the work I've done in specific disability is actually those people who are deaf and hard of hearing and who use sign language. So I've worked a lot with the deaf, blind, people with hearing impairments, but I've also worked generally with caregivers, especially running parent groups in schools as well as in the community, doing sorry, I will not allow other people to record. We will share the recording, don't worry. And I have been privileged to also do that at the policy level with governments as well as in the private sector. So these are just more examples of more conditions, and there are so many, we can't say all of them. So when we talk about palliative care, especially for terminal illnesses that are progressive, we're talking about the care that is needed not just by medical professionals, but by informal caregivers, to which focuses on relieving the symptoms, reducing pain, improving quality of life. And when we talk about palliative care, we want to address physical discomfort, manage pain, and offer emotional and psychological support to both the patient and the family. So we do have quite a number of different hospices, hospitals providing this, and it's not the work of medics only. Caregivers have to be quite involved. And some of the conversations usually around palliative care is about end of life decisions, and their caregivers are directly involved. We've got to talk about advanced care planning. For instance, if somebody is no longer conscious and there's somebody else has to make a decision, maybe about the next level of care if they need to go for surgery or anything like that. So decisions about interventions and medical resources. So we know that we have now a lot of people writing down their final wishes, such as for organ donation, funeral arrangements, distribution of assets. That's really at the end of life stage. And now it's becoming more and more common for people to indicate even a will about what they would like the family to do after they pass on. So it's important for people with terminal illnesses, any conditions, and their family to have a strong support network. So this is what this conversation is all about. It's a community of care. A lot of people want to know more about specific conditions, autism, this dementia. Thank you so much. Keep your questions coming. So we are focusing mostly on what caregivers can do in this situation. So I may not be able to cover each and every condition, but I can help with basic advice on the knowledge you need and the kinds of resources you can access. Yeah. So it is worth noting that although medical and research is focused on finding cures, it's also very important to offer hope for individuals. So the work of a caregiver is very important. If not anything, just giving people hope, very, very critical, because with hope, somebody has optimism that they can keep the fight, they can continue to live for as long as possible and with the least amount of pain as possible. Yeah. So we talk about terminal illnesses being progressive. What does that mean? Most of them will worsen over time and will have a significant physical or mental decline. So when we talk about prognosis, we are talking about the prediction. And doctors will typically mention, because of all the factors of a patient, they will say how long this patient is expected to live. And some people have been known to go way past what the doctors have said because of the role of the caregiver. If they know they have someone to stand with them, even if the doctor has given a pronouncement on the prognosis, they might be able to, get comfort and stay even much longer. So as I said earlier, some of these pictures may be disturbing. We do have a lot of terminally ill patients in our midst, and I didn't mean to traumatize anyone. If it is too triggering for you, you don't have to look, but I'll try to pass them through faster, So we have a lot of cases of physical wasting, emotional suffering as well, mental, even spiritual. And you can see for people who need a lot of caregiver support, especially the more severe, we talk about severity and things like that. So we will need to really get organized as caregivers in order to best care for people who are terminally ill. You can see some of the conditions cause wasting in the body, and you can see the physical toll on the body for people who are struggling just with terminal illness. So a lot different examples I've already mentioned. A few more are like cancer, end-stage organ failure, ALS, Alzheimer's, I've already mentioned, late-stage AIDS. We still have quite a number of others. And the idea is that the diagnosis can really impact the person and the loved ones. And many times also we find families coming together. Families are keen on beginning to discuss about end-of-life care and major decisions regarding the person. So some examples. Cancer, we do have quite an increase in different forms of cancer now: lung, pancreatic, liver, brain cancer, and those can be terminal. And the most important thing with a lot of cancers is early diagnosis, so we can aggressively fight off the cancer before it becomes advanced. HIV/AIDS is still there. Quite a number of infections can progress to AIDS depending on how strong the immunity is, and we have to take care of the CD4 levels a lot. Otherwise, if it's untreated, if people don't take care of their health, then it becomes worse. But if people take good care of their health, then it can almost go unnoticeable that someone has HIV. Then we have ALS as well. As I mentioned earlier, that's a neurological disorder that weakens even the muscles. And when people have really weak muscles, as you saw in the earlier pictures, they can't even turn. So caregivers will be at hand to assist even more with physical, what we call activities of daily living, or ADLs. And then we have Alzheimer's, which is a degenerative brain disorder which affects memory, thinking, and behavior. And it is currently incurable and ultimately terminal. It's pretty scary for caregivers and their family members when their elderly person cannot remember them at all. And so some people have felt anger that somebody cannot remember them, but remember, it's a disease that affects memory. It's not like the person is planning to forget you, Parkinson's disease is also a nervous system disorder. You've seen a lot of times people ending up with Parkinson's and multiple sclerosis may lose their ability to walk, may need to be on wheelchair in order for them to move from time to time. And these diseases can also reduce life expectancy. So those are some more examples. As I said, I was just trying to touch on a couple, just a few. COPD, the pulmonary disease, a lot of bronchitis, emphysema. As people get older, they do need some new vaccines, such as of pneumonia. A lot of elderly people actually just die of pneumonia. So it's good to know that after a certain age, you do need to go for another set of vaccines, because the ones when you were born and had to go when you were a baby, typically also will wear off. And so in advanced age, you do need, adequate care for stuff like that. And then we have renal disease that affects the kidneys, no longer able to function. You've probably seen sometimes people will present with oedema, which is like swollen legs, and because the kidney is not functioning as well. So any organ that's failing will be a cause of an illness. Heart failure, very common nowadays, mostly brought about by lifestyle conditions, cystic fibrosis. This is a genetic disorder. You'll see it in the digestive system a lot. And some people, you just have symptoms or not. And then after a while, you really, really have to go for proper testing in order to properly diagnose any of these things. So again, this is probably the most important slide. With all those medical conditions, they vary from person to person. The progression may be different. What then can caregivers do? You need to ask your loved one what they want. You need to create a wish list. You need to respect their dignity. This is very important. You need to share memories from the past. It is said that even if people are really sick or even they are dying, the sense of hearing, if there are people who can hear, still they are up to the last minute. So you need to get their affairs in order that they are feeling peaceful, and ask for additional help. This second last point is so important. We talk about communities of care. A lot of the questions you are asking are about one person not having the answer, but all of us together being able to do that. Especially when I work with the elderly, I do have a group I run called Elderly Carers, and we provide domiciliary support for the elderly. What we know is that it can be draining even on the caregiver. So sometimes what we want to do is create a rota and rotate so that not one person has the burden, for instance, to cook or to clean or to spend time with loved ones. Nowadays, because our society has become increasingly more lonely, the elderly are left alone a lot, and some of them will just need company, not even much else. They can do maybe a lot of things for themselves. They just need company. So it's good to really listen to what the person needs. And then as a caregiver, you get to simply be there and be a friend, be a friend if it's a family member or a community member, so that we are not neglecting people who have special conditions. So, as I said earlier, there are conditions that can progress and become worse over time. So we do have, you've already seen from the pictures, fatigue, weakness, pain, loss of appetite, loss of weight, difficulty breathing. Those are some physical symptoms, nausea, vomiting, a lot of incontinence issues. And it is important that we even think about getting adult diapers for especially those who are elderly and no longer have control over their bowel or their bladder. And keeping their dignity intact will be important, just getting them even more adapted beds that can come up and go down. And then swelling, I talked about edema in the legs and the feet, sleep disturbances, a lot of that illness really does affect sleep. And those physical symptoms also become psychological and emotional symptoms. If you're not sleeping very well, you'll probably be stressed, isn't it? That can lead to depression, anxiety, confusion, disorientation, and emotional distress. So we have a lot of fear, anger, grief, and other intense emotions. Most of them connected with the loss of control. Just feeling like you can't do the things you used to do and you don't feel normal. You want to eat what everybody else is eating, but you're not able. So people feeling upset, and also the caregivers having what we call vicarious trauma, because they can see how the struggle is real for the person who has a condition, and they also can feel the pain on behalf of the person. So vicariously also getting affected as the caregiver. And obviously we know through the stages, people can progress with mild or no symptoms. A lot of people with cancer don't even know until it's around stage 3 or 4, because a lot of cancer symptoms have no pain, okay? Then we also talk about progressive decline. It gets worse, and end stage is where it's become very severe and the body is actually shutting down. So slowly over time, somebody is actually dying and they need more intensive support. And finally, when the time comes for the person to pass on, then the timing really depends on, individual factors, and some of it can be more sudden, some can be more gradual. So what then is the emotional and psychological impact? While the event can happen in a short time, people don't forget it for a long time, especially those who've been caregivers. You know that those are common experiences and challenges faced by both the individual as well as the family. So we started with what happens when you have to cope with denial. At the first stage, we have a lot of shock and denial. And I mean, to cope with diagnosis can bring a lot of disbelief. Like you would ask questions like, why me? Okay. Or many people get stuck with the reason why, the reason why. So there's a lot of struggle to accept the reality. Then anxiety, fear, a lot of people become emotionally in pain. They feel a lot of anxiety. Then there's usually a lot of depression and grief, just feeling really low because there's a loss and there's a lot of mourning. There's something else we call anticipatory grief, whereby just before death, we can already begin to sense our bodies are failing. And so the idea that, you know, it can be particularly challenging that somebody is feeling grief even before an event has happened. Then we do know there's a lot of issues around loss of identity and sense of control. A lot of the work I do has got to do with orientation and mobility training. So if somebody has an acquired condition, for instance, deafness or blindness, it is important to learn to do the things you used to do when you could see or hear before, you know, the condition started. And so that loss of independence does create sometimes problems with self-worth and self-esteem. Then relationships and social support. This is very important because a lot of people used to be able to move around. Now, because they are bound in one place, they start to feel lonely and isolated. And many people around them have got to learn to remember to come where they are. And that will make, you know, not only the person with the condition, but also the caregiver struggle with, you know, that kind of loss in the relationship and social support, especially with reduced mobility, for example. Then we have something called existential concerns. These are more spiritual questions about mortality, facing death. You know, people grapple a lot with their spirituality, faith, and afterlife, and thinking about all the things they need to do to make their, you know, transition peaceful. So those are some concerns that people have. So the treatment-related challenges, we do know in this country, there is a problem with adequate access to care. So that adds to the burden. A lot of people turn to fundraising from family and friends. Sometimes the help may be few and far between, and all the disruption in the daily routine also creates a lot of problems. Again, another clarion call for everybody to come back together in order for us to create some community transformation around taking care of our loved ones. You've seen a lot of us deciding, instead of doing any treatments in Kenya, for example, people will go to India. You know, so a lot of decisions made about the care and treatment come with a cost. And sometimes you'll find the resources are not so many. So we have already talked about what palliative care is for terminally ill. We also have hospice care. It's a specialized form of palliative care. People who have maybe 6 months or less life expectancy, and it emphasizes on end of life pain management and emotional and spiritual support for the person and their family. Then pain management has, you know, a lot of focus in this field because for caregivers, you really have to check that the person who you're taking care of is comfortable, you know, and there are many techniques, not just giving medication, like movement, physical therapy, relaxation exercises, even just breathing, you know, and what we call alternative therapies. There's quite a number. I can't go into all of them today. Then obviously we need a lot of emotional and psychological support for the individual and their family, groups, and all the different players or stakeholders. And then spiritual care, most important for people who've had a, you know, spiritual life to be able to connect and have a peaceful and supportive environment. We've talked about advanced care planning, where you have to give directions and make a will. And making a will is usually a good thing when people are strong, but sometimes caregivers and family members will be scared to ask a sick person to make a will because it might upset them. So in this culture. I know that is very debatable. And then respite care, when we say that, we are talking about when caregivers take shifts and they're able to recharge and get someone else. So involving friends and family is very important so that there's no lapse in the care of the person. And also when different people experience the person, maybe if the person is also difficult, then as caregivers, we can also all get a share of the work, not just one person doing everything. This is always a problem, especially when you have an elderly person and maybe siblings who are not united and things like that, who are the children. Then, of course, symptom management. All the time when people have conditions, we have to keep checking what else is going on with appetite, breath, energy, and things like that, and even their mood. And then communication and decision making is very important. It has got to be done very effectively. And we talk about alpha caregiver, who's the main caregiver, who needs to be the person who has got to have the final executive order on any situation. And then we talk about, other levels of caregiver. But the whole idea is to have honest and open communication and no judgment so that people feel comfortable to talk. And actively listening at the person, maintaining eye contact, acknowledging the person's feelings, and also helping the person to feel comforted and understood, and also respecting their dignity. We had already said that before. Remember, because of people's diminished autonomy, they may feel, that they are not as important as they used to be before. So empowering the person themselves is very, very important. So when we do advanced care planning, we've got to give advanced directives to healthcare providers and provide legal documentation. And sometimes we have a lot of issues now in our country because sometimes people are abandoned in the hospitals and there's no next of kin, there's no person there to indicate what needs to happen. So there's a need for multidisciplinary discussions, which involve an entire team of like doctors, nurses, social workers, counselors. This is very important because we've got to help to navigate those difficult decisions, especially for those who are abandoned in the hospitals and their caregivers take off, So we need a lot of emotional support. I'd already mentioned that. And family involvement, family meetings. We have a model called family group decision making, which is very important. And it's crucial for the family to not ignore the patient's wishes. We have to make sure the patient's wishes are included, even as the family is deciding on the next decision. And we always have to be flexible, revisit, adapt, change the decisions as we go along. And then we now know support systems will be most important. So as the caregiver, you can't do all of this work alone. You've got to have family and friends, palliative care teams. These are all the professionals, support groups. We now have quite distinct support groups. I'm sure we also have some of my colleagues here who run support groups, and these are very powerful because these are users, these are survivors, these are people who already have a personal lived experience, so they share directly, support strategies, for life. Then, of course, we have mental health professionals, and that's where I really come in as a psychologist or counselor to assist people to navigate the complex emotions. A lot of the work also has to do with behavior change and attitude change, and having people know what they can do in specific situations. Like some of you are already asking some very specific coping strategies. That's the work of mental health providers like myself. Hospice care, I already said, this is people who are in the final stage, maybe 6 months or less. Home healthcare services. Nowadays, we have very dedicated professionals who can come to people's homes, and that really assists people, to get comfort within their own home. I'd already talked about spiritual or religious support. That goes without saying. Now, lastly, let's mention some ethical considerations. How do we ensure that we respect the person's dignity or autonomy? What we call beneficence or doing good. When we talk about non-maleficence, we mean not doing bad or not doing harm. And then when we talk about justice, that's obvious. We are talking about equity and access to care. So there are some considerations there. We have to really try as much as possible to inform the patient at any stage about the options, decisions being made, and if this patient or person has an an opinion, we have to take that into consideration. So we have to consider the person's preferences and values. Then obviously, for pain relief, we really also have to negotiate. We have to make sure the person is as comfortable and in the best dignity as possible. Then obviously there are people with diminished decision-making capacity. In those cases, we talk about the best interests of the patient. And then end of life choices, very important, because we've got to ensure that we have thoroughly argued for and against any decision, because withholding care or treatment can have very bad consequences. So the idea of getting support and guidance in making these decisions, then even caregivers providing empathetic support will be very important. A lot of times it's because everything is happening so fast and patients just need to be helps to cope with even the fears as they are listening to the facts. I think in the medical field, we have really failed because we give people raw facts without any kind of support, and that's a problem. Then obviously we have to look at cultural and religious considerations, especially in healthcare. We know sometimes we have to check that the same gender is there when we are talking about a decision about something, because of culture. And then justice. This is the last slide. We've got to really ensure equitable access. And how do we do that? We know that we have people in different socioeconomic levels. There are so many discriminatory factors in the health systems. We've seen a lot of cases going to the media with people entering into facilities and not being able to access treatment. So how then do we make sure that there is resource that is adequate and everybody can utilize? That's still a complex question that as a society, we have to all answer together. How do we make it fair for everybody who needs, for example, when we had COVID, we had a lot of people needing oxygen who couldn't even get. So how do we do that? So that will be a question I'll throw to us, all of us, so that we can think about that complex solution of equity and justice. And then lastly, so far as we have life, we've got to protect it. We've got to think about the dignity of people, and the family of the loved one will also be suffering along with a member. And all the way up to death, there's still something that the family can do. So it's not all lost. The family can still progress with a person with any condition, and what we need to create are really effective communities of care. Then we have different cultural expressions for mourning and dying. I think we should stop comparing each other and maybe expecting everybody to mourn the same way we do. But I think in this culture here in Africa, we have very, very well developed bereavement support and mourning support. A lot of people from around the world have come into Africa to see how we do it. There's always people coming together, and that's wonderful. So I think that should be strengthened, and that is something that should be really encouraged in order for people to be able to bury their dead. That is the end of my long presentation, and now I'll be happy to take some questions. Thank you so much. John, James, can you hear me?
Yes, I can hear you clearly.
All right.
Thank you very much, Dr. Joyce, for the wonderful presentation. And I think now we can be able to use the remaining minutes to get the questions from the participants who have been able to join today. And so that they can be able to attend to them. Maybe they also had different needs. They can ask the questions so that they can know how to help maybe the family members who have terminal illnesses or other, what we can talk about the other disabilities. And also, I think it will also be very important. We will also see how we can, as the family members, we can be able to maybe you can ask any question, maybe how well we can be able to attend to such people in our family. I do believe in one way or the other, mostly you find in the family, in our lifetime, we have somebody with a terminal illness. So I think at this point, in case someone have a question, they can raise up their hand, or they can note on the chat. Yeah, thank you. Any person within a question can raise up your hand.
Will we start with the ones that were typed in the chat?
Maybe you can start with the hand from the chat.
Okay.
From my
So
page,
I
I will not
see. Yeah.
You can check from your page.
Yes, no problem. So I see a question here. I want to know more about autism and taking care of the elderly. Yes. Then somebody else asked about autism. I'm trying to combine. I want to know more about autism. I'm taking care of 2, 7, and 4. Okay. So quite a number of people asking about autism. How can we organize support for autistic kids in a normal school setting? Really well asked questions. Thank you, everybody. So already 3 questions there on autism. So I would say the first thing is definitely as caregivers, the top tip in supporting people with autism is establishing routine. Okay, as we said earlier, autism is a developmental condition that affects, communication, and you'll find that if at least you can manage changes and transitions in the routine, it really goes a long way in creating a sense of normalcy for the person or the child with autism or an adult with autism. So keeping things just the way they usually are, even arrangement of objects in a room where they are. So for the one who asked about the learning environment, most definitely integrating their interests. Maybe you'll find that a lot of people with autism have a particular gift. There's something they like arranging. And that would be nice to communicate clearly with the people in the classroom so that that can be coordinated so that what's happening at home is not very different from what's happening at school. Then, of course, we always talk about parents working along with teachers or carers. So parents and carers working with teachers. And obviously, as a caregiver, because this talk was mostly on caregivers, you'll see I was not focusing on every single condition. It was mostly what caregivers can do generally. It's build your own resilience. We say generally, it's also good to have your own self-care plan, because a lot of times when you are trying to settle even a child with autism, we don't say autistic child, we say child with autism. When you're trying to put up all those strategies, it can still be a little bit overwhelming. So ultimately, still taking care of your self-care, increasing that and making sure that you are, liaising with, there are now really good schools with teachers who are trained in special needs who will be able to give even more strategies and tips. So that one is about, autism. I got about 3 questions. So that was a very popular area that I think most people want specific tips on what to do. Then about taking care of the elderly, and somebody has also asked a question that's related. How do we give hope yet the client and relatives are aware of a terminal situation? Well, spirituality comes into play there. We know that hope has a level of what you call bounded optimism, or optimism that's not too wild. It is realistic, okay? When we talk about realistic optimism, we are saying that we may not all be perfect as human beings. If you are a 3 out of 10, can you be the best 3 out of 10 that you are? That's what we are saying. So it is actually possible to get, someone to have hope, even when they are aware of a terminal situation. Of course, we know people are different, their preferences are different. I don't know if all of you have ever gone for a HIV test. If you ask people on the street, some people will say, I don't want to know if I have HIV or not. But maybe knowing will be empowering. If you knew your HIV status and you took good care of your health, then you don't have to be hopeless, Then someone asks, dementia is reversible. Is it for all ages? A really good question. We are now having younger and younger people with dementia. Generally, it has been associated with older age because that is when we have brain decline. Yes, it is reversible. A lot of work has been done in researching how dementia can be reversed. For example, if it's still very early or not so severe, people can learn memory enhancing strategies. when you play games like chess, you're activating the muscle, the muscle called memory, okay? When you do dancing, okay, if you're getting older and you start doing pastime activities like when you dance, when you dance, you have to really remember how to move, especially for the coordinated dances, maybe the ones you dance in pairs and things like that. So those are very simple yet very important ways, to improve memory. We also increase memory aids for people who are getting older, because maybe they need to put their medication in a certain, order, and put some containers with some labels in order for them not to forget. So the idea of, again, reorienting people to improve their memory. Then we of course, we know the role of diet. If you add your omega-3s, you add your nuts, you add, a few things, you might be able to, improve your memory. So can dementia on its own progress to terminal stage, irrespective of management? Yes. So again, so many factors. In medicine and in psychology, we never put a single factor as a reason or a cause for something. So different presentations, as unique as you can see the number of people in this room, is how the presentation of the illness can be. So yes, it can progress to terminal stage even with management. So all we try to do is alleviate the symptoms as much as possible and give people the best, freedom and independence as much as possible, yeah? So to learn how to take care of a sick or an elderly person, or a person with a condition, or a person who's neurodivergent, or a person with special needs is important, because then you can prevent a lot of things that would happen if you don't know. But with knowledge, you can prevent and control, things like that. So a lot of questions on autism, dementia. Then we have a question here on cerebral palsy. I want to know about CP and how to handle my child underwent surgery 2 years ago while in theater, went into coma and lost everything. This is very, very important. We need to find out, and whenever, especially we are just about to go for surgery, what's the surgery for, what are the risks, and we know we may never be able to completely prevent a lot of the problems, that happen. But what we want to do as much as possible, is to also, cope with this situation. I'm very sorry. I'm not reading names just because of confidentiality, but I'm very sorry for what happened. And in terms of the loss, we do know that CP can affect not just the body, but also the brain. And to a large extent, that will be actually a lot of work around letting go and handling, what we now have, which is still a life that can have, still some functionality, even if, a lot of brain functions sometimes can get affected, but somebody can still be assisted, to do what they're able. So, okay. Trying to see if there's any other question there on the same. I'm trying to put the questions together. Yeah, somebody said, I would love to hear about dementia, national statistics, and also about Parkinsonism and where one can get assistance. I know we do have a survey that the government is starting from this month of July. They promised that they will go into the counties and look at statistics for both addiction, drug addiction, and mental health. So I'm going to be very keen to hear the county per county level statistics. I don't know that we have national statistics on dementia. I think a lot of our conditions are not adequately mapped. We do have general statistics for disability. They may not be up to date. So I'm not too sure about that specific answer, but I would suggest that maybe you ask where you can see, if you visit any hospice or palliative care, you might be able to find some data there. And those are places you can get assistance for things like that. We do have now, at least with technology, a lot more groups, even online groups, as well as physical groups. So you can actually find places where they're specific on the condition their focus is on. I see a raised hand, so I think now we can mix and match. So we'll take Brian Omondi's question, and then we'll continue with the ones on the chat. Brian, welcome.
Good evening.
Yeah. Good evening.
I'd like to know, I'm in the public health sector.
Yeah.
and really wish to know which are some of the what are some of the institutions you recommend someone can go for those caregiver training.
Good question. So I do have a number of them. This is one training you're already in here, although today was a sensitization webinar. There are quite a number of different, as I said, the way the landscape is organized. Some of them are disability specific. Then we do have the more broad cross-cutting disability or special needs organizations that have most of them. The one-stop shop is the government office, obviously, the National Council of People with Disabilities. You'll be able to get a lot of information there. And then, as I said, in the private sector, you can get disability specific. And then also you might be able to have even other groups, maybe women only or young people only or elderly only. So there's an entire space of course, we need many more trainings. Of course, we need a lot more trainings. We need a lot more support for caregivers. But now, increasingly, and even online, you can also go and get some global free trainings, actually. Some of them you pay, some are free. Thank you for that question. Irene wants to learn about Down syndrome for her teen and how to help him learn human behavior. Very, very interesting question there. A lot of people asking specifically what to do, how do you make a decision about a terminally ill person on machine with death staring and the doctors there? Yeah, it can be very unnerving. So on the Down syndrome and how to learn human behavior, there are so many techniques. We use social stories a lot with people with Down syndrome. And, with social stories, people relate to stories because they're easy. They are relatable. You can actually create a social story to help people remember how to wash hands. We had a lot of social stories used during COVID, to have people remember to keep washing their hands. And that's just one out of many techniques that people can use. So in order to learn, because what we are dealing with usually is delayed milestones when we talk about developmental disabilities, yeah? So see if I have any other questions. Yeah, I am seeing a lot more questions now coming in. I don't see any other raised hands. How do you deal with a situation where the terminally ill tells the doctor not to disclose the nature of the illness and the family insists they need to know? It is very common with HIV/AIDS, yes. It's a very common dilemma. And this is where mediation, negotiation, and arbitration sometimes will have to be done, because usually what's the reason why information is withheld? It's because of the impact. And that is where the counseling and the psychology support really comes in. We know that even if people get upset at the beginning, they will go back to their reserves of resilience and they'll make it. It's better to deal with what we know and we can handle. And to that level, it brings some sort of control. But we know some of the dilemmas have to do with safety, especially because we know sometimes disclosure can lead to violence. It can lead to, and what we have in the Patient Health Information Act, or the laws around patient health information, is that we have protected information. We have information that the patient has a right, whether they want it said or not, okay? So we do protect sometimes the information because of safety concerns. We do know sometimes violence can escalate in a family. So it's usually about timing, wisdom, and the presence of a third party who can actually control the situation, so that people are not just being given hard facts. You see, that's the issue. People need to be given the facts as well as the antidote or the solution or the support, to be able to absorb the facts. So I think that's the situation that many people are finding themselves in, that dilemma of the doctor not disclosing, but the family wants to know. And it's because we are not having enough counselors being integrated in the healthcare system to do the work of the conversation that needs to happen. It's the shock and the anger and the upset that needs to be managed, yeah? So I see a question. I work directly with caregivers of special needs children who are on the severe spectrum. The biggest challenge is that they feel the children need 24/7 care, which hinders them from self-care. Most don't have social support. How do I help more? That's a brilliant question. When I did program, a huge program, having more than 150 parents, we found that a lot of parents forgot to also take leave. They forgot to rest. They actually were working throughout, and they felt that because their child with special need was already emotionally attached to them, nobody else could do the work. But then you realize that one of the interventions was, like, for the urban parents, we told them that if you have a house girl, for example, who comes Monday to Saturday, then this house girl, typically, in most of our homes in Kenya, we have a domestic servant who needs to go off on Sunday. So one of the interventions was to get another domestic servant who can be a day bag, who just comes on Sunday only. So as to relieve the parents of the burden of having to take care of everything on that particular Sunday when it's also the family day. So that's a very simple intervention at the household level that manages the situation of feeling overwhelmed. So just getting some more rotation. We talked about rotation of caregiving and spreading the work. A lot of mothers feel blamed, they feel burdened. Most of the husbands will leave them because the husband will say that the wife is the cause of the condition. And this is very typical in our culture. It is usually blamed on the mother, and most mothers end up being single mothers, and they're very overwhelmed. And some will end up also abandoning the children after they are abandoned. So thank you for that question. Then somebody says, what a really nice presentation. I learned a lot. Any help of places I could get to study the caregiving course in Kenya and Tanzania? Yeah, let's keep in touch. There are quite a number of places where you can go for training. As I mentioned, some people here are already doing the work of training others. I also train a lot of caregivers, both informal and formal. Then give tips on how to make autistic kids realize their full potential. I think I already covered that. I was talking about structure, routine, knowing the preference of the child, and connecting with, the other supports, like, for example, the teachers, specialists in autism, and things like that. So it's all about creating a community of care. For starters, what can we do to minimize burnout, such as, giving out? A lot of people are giving and they're giving and they're giving and they're not replenishing. And so the simple solution is spread the work. Do not be alone. Do not feel alone. You don't have to really feel overwhelmed when actually we are born and we grow up within relationships. So the idea that we all have to see each other as each other's keepers, and with the Ubuntu philosophy, really reach out. A lot of times when we are also burning out is we haven't asked, for help. And I know resources are scarce sometimes, and people will cost every single job, especially in urban areas. You find nowadays, you even have to pay if you want your elderly parents to have someone to keep them company. So it's a very monetized, it's a very tough, very tough economic times, but there's still spaces to come together, religious communities providing a lot of that kind of help, Then we have a question here. I am a parent of a deaf child. Early years was very challenging. However, maintaining momentum on rehabilitation was useful and important to prioritize me time. Yeah. And feel free to seek help or accept help whenever given. I really like that part. The other day, a friend of mine said to me that how they accept help is sometimes people ask her, what do you need? And she just says, I want someone to cook and bring me food. Now, if today you wanted to eat rice and cabbage, but somebody brought you ugali sukuma, just appreciate the ugali sukuma and eat it, because this person is trying to help you. You don't have to feel so stuck. You can actually say to people what you need and they can help you. And the kind of support you receive, you've got to learn to receive it as it is coming, not necessarily be too entitled to a certain kind of help. So I really like that point. Thank you so much for that tip. And then I agree on the gap of not having enough counselors to support families. It is very important, especially on processing the diagnosis. Yeah, a lot of people are struggling with coping with the diagnosis, which is affecting the treatment. Because if you don't accept the diagnosis, then you cannot take, sensible steps whenever you need to make a decision on the illness. What happens to the deaf people who seek treatment in a facility without an interpreter, and maybe they will only write in their own way? That's a really common challenge. I work primarily with people who are deaf and hard of hearing, and I've had severally to escort people literally through the big facilities. I'll not mention names of the hospitals we have in this country, some of which the problems are about resourcing. Maybe you only have 1 or 2 nurses in an entire facility of over 3,000 healthcare workers who can use sign language. So now we're having increasingly more and more trainings in sign language so that people can be more integrated. And whenever, any person with a special needs arrives at a facility, they should be able to be accommodated. Is being expected considered a disability? No, it is not. However, it does present special needs. I've seen a lot of people asking, oh, if I'm expectant, should I tell my new boss of the new job I'm going into that I'm expectant? It's usually again on the person. It's the decision that you want to have, and based on your own wisdom, if it's going to be in your favor. Sometimes it's good to mention that you're getting into a new job and you're heavily expectant of a child so that this job can organize, the HR can organize a good maternity leave in good time if you've just joined a new job. But otherwise, being expectant is not a disability, it's not considered a disability, but it can present some special needs over time. Thanks for that question. Any other? Feel free to raise your hand. I don't know if I've answered all the ones that were in the chat. I'm trying to check to see if there's any chat I missed. Anybody else with more questions, comments? Okay, I don't see any more. I don't see any hands raised. Therefore, I would like to hand over back to JK.
Thank you, Dr. Joyce, for the wonderful presentation.
I see. Sorry, I see a new question.
Yeah, there is.
Okay, take it. Okay. Somebody's asking, kindly comment on bipolar and management in a school setup, especially where the parent may not be cooperative. I'd like to know the age of the child, but bipolar is one of the mood conditions that have to do with a very high or manic mood, or a very low or depressed mood. And from time to time, you'll find that people with bipolar really struggle in school setting. And especially because bipolar will have effects on relationships. Remember, if your mood is too high, you're too ecstatic, or it's too low, then there are other problems that may come in, such as energy, motivation, things like that. And so how do we manage it in a school setup where the parent may not be cooperative? Sometimes parents are also struggling as caregivers with coping with the diagnosis. So if it's already a diagnosed condition, I think it would be wise to continue having parent-child conferences or meetings, most importantly with a trained professional like a counselor, because these things take time. Counseling is a journey. It is not a one-off fix for every problem. So we want to, first of all, educate, inform the parent about the impact. It's one thing to know about a condition, and it's another to see exactly how the condition is in the person's life. So that's the entire idea. And then with proper assessment, I see you've given the age 14 to 16 years. So that's a teenager. With proper assessment over time, we can handle a lot of what needs medical attention. Like now there's good medication to handle mood stabilization. Then now we can work on, after that, we can work on behavioral strategies. Like, for example, if someone is in manic episode, they may have very little need for sleep. They may be so excited, they don't even want to sleep. So what this person may need is some medication in order to be put to sleep, or for them to manage to sleep in order for them to be more productive during the day. So things like that. And I'm seeing all the other comments about thank you. The talk is great, informative, educative. Thank you also for your kind attention. Somebody says, may God bless you. Then there's a question again. Is there a link between the ability to hear and the progression of dementia? Not exactly. The only link I would say is access to communication, because what we know is when people get older, if you can speak more, use your brain more to speak and to converse. If you have more conversations as you're getting older, we know, even whether the conversation is in sign language or in verbal, we know that we can slow down dementia. That's why we encourage people who are older to keep speaking. I know a lot of you, if you've had people who are older than 65 sometimes speaking and repeating themselves, maybe you've been irritated listening, but from now on, you can just be patient with them, let them continue talking, because what we know is that that is really helping to activate the brain, and those things are very important at old age, to be able to keep the brain as active as possible. Remember, the body is already wearing out, but the brain can still be kept in good tip-top position conditions. So things like that. Do we as caregivers need to have goals, and what can we do if intuition clicks that one doesn't match the preference? That's a really good question again. Yes, we do need to have goals. It's very important to have goal-directed behavior. Why? Because when you're doing caregiving, whether you are an informal caregiver or a formal caregiver, what you will encounter is your own experience of the person as well as their experience of the condition. So it's really good to have reflection about what you're doing, which actions are actually what the person prefers. I think most cases of abuse of people who are sick have been like people trying to force them to do things. Like maybe you have someone who's refusing to eat, maybe because that's not their favorite food. So you need to put the preference of the patient. If they're saying there's something particular they want to eat and you can provide that, then it would be best to use your intuition to actually change the food around, not to say, oh, because I've cooked, you have to eat this, So as caregivers, we have to be very discerning and reflective, so that, we can serve our people with different conditions more effectively. Yamwange, you raised your hand. Welcome.
Yeah, thank you, Dr. Just one question.
Yeah, sure.
You've talked about terminal illnesses being an issue of family. Yes. And then now, all of us that have been on this call can understand the emotional distresses, understand the physical needs. And now, how do you bring in family, especially where some resent, some are difficult, and some have left the parents on their own, or even to one of the siblings who is waiting to take up? How do you negotiate such challenges?
That's a really good question. One thing we say, especially with adult siblings, is we shouldn't compare. So sometimes you'll find with sibling rivalry, it's very common, sibling jealousy, sibling rivalry. People have different abilities. So if you have ability to assist, for instance, your parent, you do it. You don't start to compare, oh, this person isn't coming and my brothers and my sisters are not helping. If you can help and you have the ability to do that, we always recommend that you do that. Now, in terms of conflict resolution, I had talked earlier about arbitration, mediation, counseling as some possible strategies. Family therapy is very important. The reason why people argue about how to help somebody with a condition is because of different understanding, okay? So sometimes there's a decision that has to be made. Some people don't think it is so urgent or important. Maybe they don't know the gravity of the situation, while others think, oh, this is very urgent, it has to be done right now. So the idea of consensus building can come out of knowledge and awareness raising. So if somebody has more accurate facts about the condition, and the reason why doctors give a prognosis is to be able to help people from scientific understanding to predict how much time they have, For instance, families need to organize fundraisers, families need to have important people informed, families need to consult with the person who the patient thinks is important for them to get some information, So it is a very, very complicated subject. We may not have time to completely go into the family dynamics, but I would say if any family member can do whatever they can do, let them do, let them not be stopped because other people cannot do. And then now let us get a way to organize conversations and to appreciate everyone. If one person, imagine we are cooking a meal now, and one person brings the firewood and the other person brings the matchstick. It doesn't mean the one who brought the matchstick is not as important as the one who brought the firewood, because how else would we light the fire if you don't know how to light a fire without a matchstick? Somebody else will bring the water, isn't it? Another person the ingredients. So we need to have a more cooperative stance and to deal with conflict as it comes. So that's a whole topic for another day, but I think I've tried to answer it as much as possible. Let me know if you're well answered. Yeah, so I see
that's okay. That's okay, Doc.
Yeah. Feel free. Somebody asked for my contact. You can go to wangari.africa and find my contacts there. And someone says, thank you so much. Now, at least I have the ability to help my sickly mom and my niece who is challenged. All right. Thank you so much for your kind attention. Back to you, JK.
Thank you very much, Dr. Joyce. Maybe I have maybe before we end the session, I have a question. For the person who have been able to meet maybe the caregiver of a person with autism. Some of them have found them having a lot of burnout. When I assess them, kind of they have trauma, and then you find they have a very strong attachment to their children, and sometimes I happen to recommend to some, they take their children to maybe a facility where the facility takes care of these persons with autism. And then I noted that now most of them, they don't want to do that. And they want just to be with the child, yet sometimes they find they are drained. And maybe I recommend they take for a while so that they can heal and regain strength, because you find some are affected in a way they're not able to deliver at work, or they are not able to function well at their work. So you find they have some clinical features. Maybe I can ask, can people with can the caregivers with persons with terminal illness or maybe persons with disability develop what we call the trauma bonding, which can make them even to be affected their personal lives? And if this so, how can we help such caregivers so that they can be able to move on well with their life, other parts of their life that they need to also continue with, even if they have someone to take care of? Yeah, thank you, Dr.
Yes. Yeah, trauma bonding is very common. A lot of times in families, we talk about codependency. Codependency is when one person's behavior seems to hold hostage everybody else, okay? Or one person's condition. So you find family disintegration starting from there. You'll find with trauma bonding, what's happening is people are completely, trauma is one of the conditions, psychological conditions, where you actually have a frozen, unprocessed, grief. And one of the leaders in talking about trauma bonding is Gabor Mate. He's actually a physician, he's a doctor, but he has spoken a lot about if people don't grieve enough, they don't process the loss, they don't feel the sadness and actually cry or do whatever it is for it to leave the system, they can get stuck. And that stuckness becomes trauma, whereby people have nightmares, they are trauma bonded. And most of what's happening there is also because we talked about neglect. So the person who is left with this burden of taking care of this person with a condition, an illness, or a disability feels neglected as well. So we have a lot of caregiver burnout and trauma that is as a result of neglect. We seem to think because they are strong enough to be with a person with a condition that they are doing well all the time. And I think people who are helpers, we rarely ask them if they are doing okay. We assume, because you see them doing this Monday to Sunday, we just think, oh, they'll be just okay all the time. So it's very important to have a lot of questions and have a lot of invitations to people so that they can feel heard, they can feel supported, they can feel held. Another intervention, and this one I think women groups do it fantastically. What we do is we create a string of visitors. Okay, so if you have a single mother who's struggling with, I was saying earlier with the example of food, you'll have maybe one person bring them food, another one bring them, good wishes and prayers. And so those are some ways we can assist people who are feeling burnt out and traumatized by the situation of having a person who is neglected, and they neglect themselves, and they are also neglected as caregivers. So is there a platform where caregivers support among themselves and share relevant experiences? The internet is exploding with them. We have physical groups in Nairobi, across Africa. We have so many. The actual question to ask is where they are, okay? So as I said, the one-stop shop for people with disabilities is NCPWD. That's a good place to start. I also said that in the private sector, we have a lot of either disability specific or cross-cutting type of disability organizations. So you are very welcome to check out a lot of these, mostly non-communicable diseases. You will have a support group for it. I know many, I'll not mention names here, but we can keep in touch, and depending on which condition, we can talk about that. We also have general groups just for caregivers, and I run a few as well. Some are closed groups, some are open groups. All right, some are free, some are paid, and so on and so forth. So some are very formal, some are very informal. So we can do that. We can do even groups that have not yet been started. But I bet you that in any major city, even in Africa now, you'll be able to find groups. These are survivors who come together to help each other. So yeah, you can find them. Anybody else with a comment, question? I think we keep increasing them. We'll be here all night. So JK, you should guide us now. Is this the last one, or are we good with time?
I think we are good with time because
good. Oh, wonderful. Halima, welcome.
Thank you very much, Dr. This is very insightful and very helpful. I'm particularly very grateful. I want to comment. As a person who had a child and even have a child living with CP, I have this to say. First and foremost, parents who have kids, sometimes they live in denial. Accepting the condition of your child is very key. First, accept it and understand the siblings to accept the child so that there is love and a roundtable care for this particular child so that the mother is not overburdened with taking care of that child. Secondly, when you accept the help that comes your way, this child is likely to get help. And for that matter, appropriate help is very important. Sometimes diagnosing this child, autism, cerebral palsy, a number of mental diseases, mental health categories of disability is very important. Sometimes a child is placed in a place where he's not supposed to be. So I advise the parent to kiss and see if their child can be placed appropriately, either in a regular school or in a special school. Sometimes kids feel stigmatized because they are being put in a school where all the other kids are learning in a different way. And this child, especially those who are suffering autism, running up and down there, it's hard for other kids to understand. So it is very important for right placement to be done for such kids.
I totally agree.
Then support group. They want to be paid for, kindly join one. It's very, very important. respect for this child and listening to that child, even the one with cerebral palsy who is not able to pronounce or even to talk, has a way of talking. Learn what you are, I mean communication model of your child. Some of them look at you in a certain manner. Some of them make a gesture. Kindly learn and see what to do with that child. Then for those who are taking care of their older parent, work with your parent as if you are the only child, as if there is no other option. But watch out on burnout. Give yourself time, help yourself somewhere, and get help from those who are willing. That is what I had to say. And I thank you very much for this, and may God bless everybody.
Thank you so much, Halim. I agree with all the points there. I really like how you that accepting the diagnosis, the importance of diagnosis is not a bad label. It's a good way to place people who need very specialized help. And then the idea of in the placement, even in school, do you need a regular? Do you need an integrated? Do you need, special unit, so that people can get appropriate help? So accepting the diagnosis, and then respect, listening. You've said there is a communication model, even if somebody cannot speak. So it's a good thing to understand somebody's language. And then if you are adults taking care of your elderly parents, you should just take care of them as if you're the only child. Don't start comparing with your siblings. And that's very good advice, very wise. Thank you. A lot more comments here. Caregivers who have lived with their child, say for 16 years, giving direct support, then the child passes on. Then there's that feeling of their life was stuck for 16 years. How can they move on after the death? That's a brilliant question. And you also say, thank you, I've learned a lot. So on that one, quickly, as I know our time is also up, is to say that, yeah, there will be normal bereavement and there will be complex bereavement. And if somebody is grieving the loss of, a special child, we know that normal grief will be probably for the length of about a year. After that, if there is prolonged grief, then we may need to now intervene with specialized help. But to be able to especially unpack the meaning of the loss, it can be a double loss because you had to sacrifice a lot to help this person. But at the end of the day, we do know that all human beings are mortal. So whether they had a condition or not, everybody has a day they are born and the day they die. Therefore, spiritual support really helps with things like existential meanings and processing that kind of pain. Thank you so much for that question. Of course, we will share the recording, and thank you very much. Back to you, JK.
Thank you very much, Dr. Joyce, for the wonderful presentation. We are grateful to have you with us today. And we will share the recording, as we have said, for those who have not been able to join, so that they can be able to also get from what they are able to run. So we are very much grateful, and I think I will be able to end our session at that point. In case you need more consultation or clarification, you can contact Joyce. You can check even from her website or information that can be very much helpful to us, so that we can be able to move on well in helping other people who have the needs and they need support. So thank you. I think we are at that point. Then we meet next week on Monday for those who usually join the JK Wellness. Usually have meetings every Monday from 7:30 p.m. to 9 p.m. So on Monday, the same time, you'll be able to meet and also learn more on mental health. Thank you very much, Dr. Joyce, for honoring us and joining us today, so that we can work together with JK Wellness to make mental health awareness the community, and also do awareness on how to help the caregivers or the families who have people with terminal illnesses and other disabilities. Thank you very much. We can add at that point.
Yes,
Yeah.
somebody is asking how to participate in JK Wellness. So maybe you can give either the link or your number or how they can join. Lynette or Tibine is asking how to participate. Team JK Wellness.
I can share my contacts so that they can inbox me. My contact is 0710.
Okay, I'm going to type it. Yeah, 0710 121 754. Yeah.
Yeah.
There we go. All right. So please take down that number and WhatsApp to James. Thank you so much, James, for your platform and for this wonderful forum.
Welcome,
Okay.
Jace.
Okay. Good night, everyone. Bye. I'll end the meeting.
God bless. Good night. Thank you.
Good night.
Bye.